So, good morning, everyone. Welcome to today's event, Past, Present, and Future, HCCNs and Health Centers Using Data to Drive Clinical Care series. This is the third in our series called The Future State of Data Integrity. My name is Elizabeth Breidenbach. I'm a Meeting and Event Specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event with my division colleague, Julia Skapik, the Medical Director of Informatics in the Clinical Affairs Division. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attending lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, presentations, and of course a Q&A. Again, the duration of this event is approximately 45 minutes, including introductions, presentations, and Q&A. On your screen right here, you should see a PowerPoint slide that indicates what the Q&A box looks like. It's located in the lower right-hand side of your computer screen. Simply type your questions into this box at any time. We will see them throughout today's session. If for some reason we cannot answer your questions at the time allotted or need additional resources to answer those questions, we'll make an attempt after the event has been completed. Friendly reminders that today's event is being recorded. All attendee lines have been muted and will be muted for the duration of this event. The Q&A box is currently open and ready for all of your questions. Simply type your questions into this box. Please select all panelists and hit send. And again, if we cannot answer your questions in the time allotted, we'll make an attempt after the event is completed. At this moment, I'm going to turn things over to Julia, who's going to be introducing today's speakers and setting the stage for you. Julia, the floor is yours.
Thanks so much, Liz. So welcome, everyone, to the third presentation in this series about the future of data and the future of community health informatics. We have three fantastic presenters today. I'm going to set the scene myself and talk about sort of the big picture, and then we're going to have John Luntz, who's the CMO of CGI Federal and a professor at Johns Hopkins, Mark Sendak, who's with Duke's DIHI and the Population Health and Data Science League, and Fayaz Syed, who many of you know, who's from Michigan Primary Care Association and a clinical consultant there. Next slide. That's the last slide? Okay, I'm going to go ahead and share my screen then. Okay. Are we seeing the presentation?
Yeah, Julia, it's on the screen.
Okay, great. So we're going to talk briefly about the future state, and then each one of our presenters is going to present a component of where we think networks and health centers may be interested in moving forward through their own future state planning. So, okay, I don't have any financial disclosures to report. So I kind of think of the data challenges as sort of a puzzle that we're trying to put together, right? Right now, much of the data is siloed, so in order for us to fill in each one of these gaps, we have to go after each one of these data sources and then sort of click them into place and make sure they fit. And, it's only when you really do a significant amount of work integrating these different kinds of data and these different data sources that you start to see a whole beautiful picture of your patient and where they're going. NAC uses a human-centered design framework to tell our patient stories and to tell the story of what's happening at the health centers. The human-centered design framework tries to bring that storytelling that NAC's always been particularly good at into a sort of a more structured way of creating requirements and telling the story of the use cases we're trying to solve. And then we use a structured way to define the stories into clinical terminologies, into clinical logic and code, into workflow design. So when we think about the future state, we sort of start with what is the current state. And this is not to sort of speak negatively about any one entity in the health information technology ecosystem, but in the past, people have felt like, clinicians have felt like they're more data entry techs. I think almost everyone who uses the EHR has that sort of sense. Many people don't feel that the systems are usable or intelligent to the workflows that they use. Oftentimes, there's a focus on billing and not so much the proactive kind of patient-centered care coordination we'd like to see. Interoperability has been getting better, but it's still somewhat poor as we talk about the amount of effort it is to bring all those puzzle pieces into a coherent data set. The code bases of many products are very large, and they're easily prone to breaking when you get updates or changes to the system. There's not enough decision support for users, and I'll say I don't just mean clinical decision support, but a function in the system that tells the user what is something for, how would they query that kind of information across the system. And data is very challenging to extract. We know we work with many of you on that, and it can be painful. So we would like to see sort of the 2.0 21st century approach to health information technology be very patient and care team centered, not just physician focused, but thinking about what are the different roles of all the users, right? Designed around workflows and able to flex somewhat for reasonable workflow accommodations, promoting primary care and care coordination as opposed to other sort of secondary use case, lightweight platform with context-specific apps so that instead of having sort of all or nothing approach to the system, you could say, well, I'd like to obviously be able to document and to order, but I also have a lot of patients with rheumatoid arthritis, so let me take in a rheumatoid arthritis care coordination suite or something. A high focus on bidirectional data sharing and testing, and I think it's underappreciated how important continuous testing is to make sure these systems work and continue to provide value and good data. It's very easy to break those connections, as we know. And really should be sort of push of a button to get all of your data out of the system, and we know that's not the case now. So the next generation approach to health IT, as described both by the international standards development organizations like HL7 and the federal government itself, is to sort of bring all of these pieces together into sort of a modernized standards architecture and approach. And that's, right now, that's around FHIR, Fast Healthcare Interoperability Resources. Each one of these blocks here are components that I would say are critical for the community health use case: clinical coordination, measures and decision support, social determinants, public health reporting, sharing information across transitions of care, and sharing information with payers. So many of you are aware of FHIR. I continue to bring it up because not only is NAC starting to do development and deployment work with partners internally and externally using FHIR, but recently the federal government updated their requirement of systems using an API to using an API that supports FHIR version, at least release 3.0. And FHIR offers a lot of good functionalities that continue to improve. This is an example of FHIR clinical reasoning. This is a set of decision support modules that were built into 3 different systems and integrated. Here's a couple of screenshots of how they looked in different systems. Here's a series of CDC-created opiate guidelines that you can actually go and download all this material, and you have free decision support for opiates based on the CDC guidance. This is a mock-up of the AHRQ electronic care plan generator, and that's derived from the work that was done by NIDDK on multiple chronic conditions, a FHIR electronic care plan guide. I've tried to put links in here for all of you to make it easier to find this stuff later. What we hope that we have is then marketplaces of materials where we can say, you know what I could really use? I could really use a good medication management application. Oh, I can download the Duke Pillbox for free at Logica Health Marketplace. Or if I needed decision support for veterans health, I can go to CDS Connect and download those. And these are both sort of open source platforms. NAC has been collaborating with some folks who are building applications that are more patient-facing. Obviously, social determinants of health and our Prepare tool would be a great item to put into the patient's hands and then get that data back into your system. This is a demo of the Prepare FHIR tool called FHIR June, and you can download that at GitHub. So I'm going to talk a little bit about COVID-19 because what NAC has been doing for the last 6 to 8 months has really focused heavily on COVID because we want to support our partners. As I have said before to some of you, we focused on the end-to-end use case, so not ignoring any one component, but looking at activities that FQHCs do around surveillance, screening, and testing, looking at case management and care follow-up activities, looking at case reporting and contact tracing, and supporting good work with analytics. This project goes around the ecosystem and wants to use data to inform new interventions and approaches. It takes sort of the approach of a registry, but our hope is because we're getting patient-level de-identified data, we can track individual patient outcomes and understand how COVID-19 affects the population and the performance of health centers and their health disparities. These are the partners in this project. The dark blue represent PCAs and HCCNs that we partner with, and the light blue are states where they also have members. So it has a pretty broad reach. We attempted to be getting a good mix of urban and rural and different parts of the country. And NAC's role is really to build an enduring infrastructure of technology tools that our partners can use as we're tracking not only COVID-19, but other important things that public health crises as they emerge. I'm going to speed up a little bit. So our data strategy, look at all different levels of analysis. Again, I'm bringing up some links that you might find useful. The COVID-19 Interoperability Alliance has a set of value sets around COVID. Those are maintained and freely available here. There's a FHIR implementation guide for COVID-19 available here. Many of you are familiar with the IIS systems that you have to report immunization data to. Keep in mind they have COVID-19 specific value sets as well. NAC has implemented into our architecture the clinical architecture terminology tool Medical into this data architecture. We're using data bricks to sort of normalize data into a data lake, and then we have sort of partition sections of a relational database. And we are deploying APIs so people can directly submit content. Here's Databricks analytic approach, and these are the kind of outputs it generates. This is an age-stratified mixture of patients with COVID exposure, suspected COVID diagnosis, and confirmed diagnosis. If you're looking for SARS-CoV test data, there are links here created under the LIVID project. You'll see this is a distribution of tests just from 2 health centers. And then this is the number of tests over the course of 2020. So there are many barriers still to COVID-19 data capture and response. I'm not going to go over every one of them because I think you're tested by them every day. But I do want to say, please reach out to NAC Informatics team and let us know where you're struggling or where you're running into barriers so we can see what we can do to advocate for you and find solutions. So I'm going to turn it over to Mark. Mark, do you want to pick it up and tell us about Greenlight?
Thank you, Julia. Perfect. So the thrust of my presentation is going to be a little bit different than I think talking about the types of IT systems that we're used to working with. And this is something that I've been involved in just recently, a new initiative that we created at Duke and in Durham. So my name is Mark, and I'm at the Duke Institute for Health Innovation. Pre-COVID, my work was almost entirely internal to the health system. For 7 years, working full-time to build, design, develop, implement, and evaluate many technology innovations in our clinical workflows. Post-COVID, much more of an outward-facing role working in communities. So next slide, please. So where we started last March was our head of critical care reached out to my team director and me asking how we can prepare for COVID. We knew that most folks would have mild symptoms or may not have symptoms at all, and that people could get through the infection, but they would need support to do so. So we built a set of tools and programs to support our healthcare workers, over 20,000 employees. Next, it was the university. We were asked by the president of the university to build a mobile app and design the testing workflows for Duke University. We've been kind of heralded as one of the success cases in the United States, over 15,000 folks using the tools that we built every day. And then lastly, we launched a program for the general public through what we called the Pandemic Response Network. And now we've had over 10,000 folks use a twice-a-day symptom monitoring program with nurse volunteers making follow-up calls for anyone with severe symptoms and volunteers calling anyone who lapses on their surveys. So despite having this, what is deemed to be success internal to Duke and for a part of our general public, where we were failing was reaching historically marginalized communities. Over 90% of the 10,000 participants in the program we launched for the local population, 90% of the participants were white. Next slide, please. So early on in May, we worked with a group called IDEO. IDEO.org is a nonprofit arm. They're probably the world's most famous design firm and actually use human-centered design that Julia just mentioned. These are 6 of the key insights that they helped us surface for how to work with historically marginalized communities. So I'll read these quickly. When communities constantly feel ignored or see resources flowing in another direction, they're primed to mistrust outsiders. For many, caring about COVID is a luxury in the face of more pressing and urgent needs. Contact tracing and symptom tracking asks the vulnerable to take on more risk than it's worth. Technology makes the public health response more efficient, but further alienates the most vulnerable. Trust comes easier between people with shared language, culture, and experiences. And lastly, holding the community's trust is a heavy load that response workers are not always prepared or equipped to bear. Next slide, please. And what we had to face was that the bridge between an institution like Duke or even local public health department and the community was broken. Our health system was not meeting the needs of our Latinx or African American communities and working closely with the nonprofits and community-based organizations that serve those communities. Next slide, please. And on the flip side, the local organizations were struggling to access services and programs and even desire to participate in offerings from a health system like ours. Next slide, please. And so where we focus now is building that bridge. And what we did early on, actually in July, we licensed all of the technology and best practices clinical protocols out of Duke into a new entity called Greenlight that has been working closely with nonprofits, city, county, and state contracts to scale the support programs and technologies in the community. So on the left-hand side, we have our Greenlight Durham implementation supporting 65 small businesses. The original ask was accommodations and food services. Now we're spanning across 10 different industries. The middle column shows work in public schools. In July, we started identifying public schools as a single use case we would have the biggest impact. And then on the right-hand side, we knew that we couldn't do this alone. This was going to take a network of organizations aligned around meeting the needs of historically marginalized communities. Next slide, please. This is just one of the testimonials from a business owner for a bar restaurant probably 2 miles from my house. But I can't tell you how many times we've met with business owners, school leaders, just people in the lay public who are facing the challenge of having to cull through all of the information and figure out what to do in stressful situations. Next slide, please. So COVID has been very isolating for business leaders. Everyone has to figure this out on their own. Next slide, please. And so what we try to do with Greenlight is surface the resources, aggregate it, coordinate it all, and put it at the fingertips. Over the time period we've been working on COVID, we started with symptom monitoring, playbooks, scorecards, the best practices. We've added on Binax now, rapid antigen testing, building out the networks of community-based organizations. And then lastly, a lot of work that we just recently launched around vaccination outreach and navigation. Next slide, please. I think these next few we can go through quickly. We use the Swiss cheese model in terms of just these policies and best practices are additive. So even the vaccine, we may need to do the vaccine and continue to wear a mask and continue to socially distance it and continue to improve air filtration through indoor spaces. Next slide. So we have playbooks written for schools and for businesses, largely adapting things from public health and filling in the gaps where we see them. Next slide, please. We have a scorecard where an organizational leader can fill out 50 questions, and we worked with our infectious disease faculty to identify the weights of the different policies. So should you focus on universal masking or buying filtration systems? Next slide, please. When Binax Now came from the state, it was essentially an offer to ship tests, but we now have kind of filled the gap by creating all of the material to help on-the-ground school leaders understand how to use these. It's an imperfect test. In some cases, we're recommending PCR follow-up. In other cases, we're recommending repeating the test on consecutive days. Next slide, please. And now what we're kicking off are town halls. In this, we've taken content from the state, from the NIH SEAL program, from the CDC, made engaging presentations about concerns, recruited folks from communities of color, African American, native Spanish-speaking physicians to help organize town halls. We have about 4 or 5 a week at this point. Next slide, please. I think this just shows the calendar of who's presenting. We try to pair community leaders and experts in each of these. You can go to the Facebook page, and this is where we're looking for partnerships as well to help scale this model outside of North Carolina. Next slide, please. So we're not going to do the demo, but folks can go to Greenlight Durham and read more about the local implementation, and then Greenlight Ready is the website that shows what we're doing across sectors. Next slide, please. So there are opportunities. We started in Durham. We're already working in Onslow. We're working in about 39 counties throughout the state with our partner, Cure Americas Global, with community health workers and looking for other opportunities to build out and scale these systems. I will say that this is not integrated right now with our EHR. Our priority here was to move quickly and to build systems that were trusted in the communities that we weren't able to reach through the more kind of typical IT development process within a place like Duke. Next slide, please. These are the leaders at Duke. It's been with a lot of operational support, and it's privileged to be able to do this work. I've told many folks there's never been a more exciting time. Exciting is one way, probably more important time to work in health innovation. Thank you. I think the next slide is just, that's it.
Thank you, Mark. That was great. We're going to move the discussion now to John Moon, who's going to talk with us about ECR Now.
Thank you, Julia. And I am going to talk about an activity that was just ramping up at the start of COVID-19 about electronic case reporting, which is essentially getting data from electronic health records and transmitting it seamlessly to public health agencies for their action. But it resonates tremendously with a number of the themes that Julia brought up at the outset. Public health is traditionally in silos. Manual processes were ruled the day in terms of a lot of public health data, clinical data going to public health. It was not a bidirectional exchange. All these things ring true in terms of the implementation, next slide, of the way that case reporting has occurred. And yet at the start of COVID-19, it was very evident to everyone that public health agencies were not getting the data they needed to manage the outbreak. That's what electronic case reporting is about. It's about providing public health agencies with the kind of patient identity and contact information, comorbidities, race and ethnicity, occupation data, pregnancy status, etc., that is necessary to manage an outbreak, but they don't get just from lab results, which is one of the existing operational streams that's helpful to public health. Next slide, please. So going into COVID-19 and having been involved in public health for a number of years, we realized that the public health paradox, that it's the worst time to get things done, is also the fact that it's the best time to get things done. And we rolled out an initiative we call ECR Now to try to take the nascent electronic case reporting capabilities that were just starting to be rolled out and implement them during the course of the pandemic. Very daunting task indeed. There were 3 major elements to ECR Now. One is to do rapid onboarding with the technologies for those clinical care organizations that have electronic health records that can do case reporting. The second element was to produce and deliver a Fire app that can be used with those electronic health records that don't currently do electronic case reporting. And the third was to, in partnership with the eHealth Exchange, Care Equality, and others, to implement a trust network that made it as easy as possible for folks to do electronic case reporting as well. Next slide, please. So this is quite the story of progress during an epidemic. And at the beginning, I mentioned that we had 187 facilities. There are 3 healthcare organizations that were just doing trial implementations of electronic case reporting. We currently have over 6,800 facilities that are now reporting and doing electronic case reporting for COVID-19, and that includes 58 healthcare organizations. Next slide. The connection involves connecting healthcare organizations to public health agencies, and from the start, when we had 21 states and Washington, D.C. connected to receive them, we have moved to having all 50 states, Washington, and 11 local jurisdictions that are now capable of receiving electronic case reporting data. Next slide, please. What has occurred in this is that over 6 million COVID-19 electronic case reports have been transmitted from healthcare organizations to public health agencies, really establishing the infrastructure, next slide, for electronic case reporting for all conditions, which is now available for 89 plus conditions nationwide. Next slide, please. So that was about progress made during COVID, and the other second element of this is this app that can be given to an EHR and implemented to add full electronic case reporting or just COVID-19 electronic case reporting going forward. It is available in open source form. It works with FHIR on the EHR side, and all the EHRs are developing their FHIR interface to support and abide by the regulations that are coming for them. And we are promoting this as an activity through a variety of means, including the ECR Now COVID-19 Challenge, which offers up close to $500,000 to support implementation of the ECR Now app for COVID-19 reporting at this time. This challenge is still open and available, and if you go to the ECR.AIMS platform, AIMS platform, one word, .org, you can find information about the challenge and what's involved in doing it. Next slide, please. The final element is that trust framework, and we were very fortunate to have partnered with the eHealth Exchange. We, during the course of the pandemic, have also implemented in conjunction with Commonwealth, which brings in well, I should say with Care Equality, which brings in the Commonwealth network as well. And so it's very easy for a provider organization to sign up, to begin to do electronic case reporting, to have the technology if they don't have it with using the app, to have the policy framework if they to support electronic case reporting, and to get going with this right away. It is a series of activities that we've been pleased with, that despite the pandemic, despite all the challenges of doing things when people's attentions have been pointed to other activities, that we've been able to move forward. And we would encourage you to participate in the challenge and to get going with electronic case reporting soonest. Thank you very much. Julia, I'll turn it back to you.
Great, and thanks so much. I should say that John's team is already helping some of our FCHC partners with this. So if there's interest, definitely go down and you can register and reach out to them and see if you can get electronic case reporting happening at your site. So our last speaker is Fayyaz Syed from Michigan DCA, and he's going to tell us about Zoom Hall patient engagement.
Thank you, Julia, and good morning, everyone. I have been asked to speak on behalf of HCCN, the current work and the future work that we are envisioning from a HCCN perspective. So I'll go ahead and share with you the implementation of our patient outreach and engagement tool, which is LumaHealth. Our goal here was to use this tool to address some of our health center control network objectives, specifically when it comes to patient experience enhancement and reducing provider burden and improving that interoperability and sharing of information between providers and patients and providers and providers. So next slide, please. There were a few things that we took into consideration. I kind of shared that HCCN objectives were definitely a motivating factor, but in our PCA has a clinically integrated network that is involved and engaged in value-based contracts with health plans. And so we looked at it, and the contracts that we had, about 20 to 25% of our patient population that was attributed as health center patients, they were never seen at a health center, or they were not being engaged. And that was one of the primary reasons we looked into this tool. The other one was obviously the HCCN objective that I shared. And then we kind of looked at what was out there available and existing EHR communications tools. They were not optimal. Some of the EHRs do have a text messaging service that is offered, but it is not anything that is desirable. And so that was an option, but not really a solution. And then our goal as a HCCN was to support the health centers with adoption and use of patient portal for the last few years. But what we have learned from our health centers is that the patient portal adoption and use has been a challenge, specifically because of not a whole lot of interest from the patients, or just because it was one more ID that they have to remember, or some of the patients that we serve at the health centers, they did not even have an email ID to share, so a patient portal account could be created for them. So those were some of the key factors that went into our decision. And what we found as a potential solution was that we looked at the research that was out there, and which was suggesting that the use of text messaging was something that could be an effective alternative over existing methods for patient communication. And we definitely looked at data. And so the research data also suggested that 20% of patients prefer receiving health information from their healthcare providers by text message rather than logging into a patient portal. Next slide, please. And so we have the Primary Care Association, we have the Health Center Control Network, and then we have our clinically integrated network that we're kind of like partnered up for this initiative, because everybody had a pie, piece of the pie in there. And so we wanted to make sure that we got together and said, hey, let's look at a solution that will help all of us. And obviously, without the interest from health centers, this was not going to work out. So there were these primarily four, partners that were involved. And what we foresaw as an implementation model was that this will be a tool that will be implemented across our network. And so we were able to negotiate those discounted prices for services based on volume for all of our members. We were going to send out the RFP, and then the PCA or HCCN will have the master services agreement with the vendor, and then health centers will have sub-licenses. And the important piece here was that we wanted to make sure that there was health center representation during these meetings that led to the decision-making of selecting a tool. So health center representation was very, very critical for success of this. And obviously, us as the staff, we were supporting all of the committee members. Next slide, please. And so just to show that we had representation from health centers, from all of these different areas and specialties, where we had a CFO represented, operations director from the health center represented. We had, clinical folks, quality folks from our health centers that were part of the decision-making committee. Next slide, please. And so we started this process back in 2019, believe it or not. I don't know where 2020 went, but it has been a little bit of an arduous process. But our goal was to get this tool implemented within a short period of time, but it didn't happen because we were at the end of the year. We were getting the RFP in place and wanted to go through the process of selection, but then COVID happened. So started back in October, we sent out the RFPs, and then we had 6 vendors that submitted RFP. I've listed them here: CareMessage, LumaHealth, Well, Relation, and Radix Health and Intrado were the ones that we received the RFPs from. And then we went and made sure that the health centers that were already using some kind of a communication tool or patient interaction tool, they found this useful as well. If we were asking them to, implement this tool and stop using something else that they were already using, we wanted to make sure that it was a feasible one for them. So we collected information from the health centers on what they were currently using and what was the cost for using a tool that was already in place. And then we went through the committee vendor review and made sure that the cost conversations happened with the 4 top vendors that we wanted to look further into. And then we finalized the top three, that is CareMessage, LumaHealth, and Bell App in February of last year. Next slide, please. You can see that COVID happened, and so everything got pushed out, and we wanted to make sure that there were a few things that we did our due diligence, and it took us a little bit more time than we expected, but we wanted to make sure that it was done right. One of the things that we wanted to make sure was, our goal here at the HCCN has always been to avoid multiple tools, multiple interfaces with EHRs that will make life more difficult for the health centers, so align as much as possible. So our agreement deliverables and the language that was finalized with LumaHealth, we made sure that there was that piece where Luma was going to work with Azara, which was our population health management tool that is being used. And so that was one thing that we definitely worked on and made sure that it was included, that the interface with Azara was critical for our success and for automation. Next slide, please. And these are some of the essential services that LumaHealth offers. So we have 2 different packages that we have offered to our member health centers: the Essential package, and we have listed the appointment reminders, broadcast messaging, gaps in care messaging, population health recall messages, and care pathway messaging as essential. And on top of that, if the health centers were willing to spend a little bit more money, then they had these additional 3 things that were part of the life cycle package. And there was a 6-cent difference for the completed visits that we were able to negotiate a price with LumaHealth between these 2 packages. And then there were these 3 add-on features that were available: mobile patient intake, guided patient scheduling, and telehealth. These were more per provider-based costs for the health centers to pick and choose from. Next slide, please. And just wanted to share that while we were going through this process, obviously we all were dealing with COVID, and so were the health centers. So things slowed down because of that, and our implementation timeline had to be extended a little bit because of the impact of COVID. And then we had our health centers working on implementing telehealth and, pivoting to virtual healthcare. And this was a critical issue for the health centers to look into. And the good thing that came out of this bad pandemic was we were able to negotiate a 90-day no-cost use of Luma Health for 13 of our health centers that could use the tool for broadcast messaging and as a telehealth platform during the peak of COVID. And this definitely helped drive the health centers to make that final decision to sign the contract with Luma Health. Next slide, please. And tool was one thing, but we wanted to make sure that for our road to success, we needed to have a multi-pronged approach. People, process, and technology is how we saw it. The technology piece was Luma Health. Next slide, please. And so we, when we looked at how we wanted to utilize people, it was the use of CHWs. There was an initiative going on to use CHWs to provide more patient outreach and engagement activities. And then we also wanted to make sure that all of the care team were receiving trainings on the use of the tool and other processes that we wanted to put in place. One of the things, next slide, please. One of the things as a process was that we wanted to develop a patient outreach and engagement guideline, which we did. It helped the health center staff to understand how often they were supposed to send the message, what kind of messages, when they need to be sending, whether it was a gaps in care message, whether it was for a new patient or just a patient appointment reminder. We were able to develop that patient engagement guideline. So in short, based on all of these things, our goal was that by the end of 2020, we wanted to have at least 20 of our network members that were going to implement Luma Health. And I'm really happy to report that 21 health centers are currently participating in our Luma Health contract. And our goal too was to make sure that Luma Health interface happened with Azara for gaps in care automation. And happy to report that that has happened actually, and 3 of our Michigan health centers are currently in that Luma Azara interface pilot. I think that's all I had to share. I was trying to run through.
Thank you so much. So, Liz, do you want to take over again? I know we only have a couple minutes left because we have to stop right around 11:45. But do we have time for one question, maybe?
My apologies, I was muted. The Q&A box is open, so if you want to go ahead and pluck a question from there to see if there's anything that's a hot topic right now for you to pose.
Okay, questions about the slide. So one question was, how many FQHCs are using ECR? Do you know, John?
I don't know that right offhand. We'd love to have more. The challenge is a great tool for getting there. I do think that the majority of FQHCs that are implemented now Ocean, which is implemented broadly for their network, and I know has a number of FQHCs in support of that. But we can do better, so we'd be pleased to talk with them about that.
Mark, a quick question for you. Do you have any insight or data that would tell us about how your new approach has impacted equity? And I don't know, Liz, we're getting a lot of feedback. Mute wherever that's coming from.
Hey, Julie, I was just going to put in my email too, and I'm happy to catch up with you, Lori. I can tell you that we're reaching an entirely new audience. So the types of small business employees in accommodations and restaurants, food services, cafes, these are not folks that have health insurance. And even a lot of the public schools and equity-focused charters, these are almost entirely Latinx, African-American children, youth. And something that I think is not appreciated about schools is also reaching multi-generational households. So within schools, it's often the most vulnerable kids who are not able to participate in on-site or even remote learning because there's multiple generations and childcare responsibilities in the home. So the more that we can view schools as a way to reach families, to help get education material about vaccination, safe practices to the older adults who live in the home, it's actually a great way to reach people. So while we don't yet have metrics saying that we are vaccinating people in historically marginalized communities, I can for sure tell you that we have 3,500 people using Greenlight Durham through schools or businesses in Durham, and over 80% are individuals who are Latinx or African American. And on the flip side, like, it was less than 10% of that community was reached by something we launched at Duke.
Wonderful. One quick question for Fayaz, and then I think we have does Lumen have RPM capability?
Not that I know of. If the person that is asking the question by RPM, they are referring to remote patient monitoring devices, then not that I know of.
Liz?
That's it for the Q&A for today. Let me go ahead and move forward. Folks on the screen right here, we do have a learning community that's going to be coming up very shortly. It starts February 16th, so everybody that was that attended this entire series will be getting an email shortly on behalf of NAC inviting you to join it. Dates are on the screen. There is a link to sign up, but I do realize that is a kind of a long link for you to go ahead and copy and paste. So feel free to take a picture message of this. Alternatively, you will receive a message on behalf of NAC just inviting you to join. It is required that you do attend all 4 events, so just keep that in mind when we do advertise that out to you. It's a learning community. There's going to be plenty of interaction, and we will invite you to join all 4 events, or you will need to join all 4 events. With that being said, I want to thank everybody for joining us for this series. It has been a pleasure having you. I hope everybody has a fantastic day. We'll talk to you soon. Thank you. Have a good day.